Very nice. We are on Facebook right now. I'm going to introduce you to our audience, Latin American, Mexican, Latin American audience, Dr. Jean-Luc. Ok, bueno, buenos días a todos, buenas tardes ya en México. Un saludo a todos desde la ciudad de Monterrey, Nuevo León, en México. Estamos en un webinario más de nuestra Asociación Mexicana en Ultrasonografía Crítica y Urgencias con nuestra Unidad Internacional de Entrenamiento WinFocus Guadalajara. Sean ustedes bienvenidos a un webinario de nuestra asociación. En esta ocasión, pues estamos, como siempre, sumamente contentos y además agradecidos porque tenemos un webinario muy especial con un líder de opinión, con un extraordinario ponente a nivel mundial, al cual desde luego le estamos sumamente agradecidos. Estoy seguro que ustedes van a disfrutar de esta reunión. En un momento más se los voy a presentar, pero antes quiero también presentarles al doctor Quetzalcóatl Chávez, quien en esta ocasión nos acompaña. Es un profesor de nuestra asociación, al que también le estoy muy agradecido por aceptar compartir este extraordinario movimiento, o más bien este extraordinario momento académico. Quetzal, si quieres presentarte con la gente, saludarlos.
Muchas gracias, Juan. Mi nombre es Quetzalcóatl Chávez, también pertenezco a la Unidad de Entrenamiento Internacional de WinFocus y a la Asociación Mexicana de Ultrasonografía Crítica y Urgencias, un movimiento que afortunadamente hemos logrado despegar en varias partes de la República Mexicana y cada día se nos agregan muchos más colegas. Y felicitarte, Juan, también por el excelente trabajo de los webinarios en esta tercera temporada. Pues vemos el calendario y evidentemente empezamos a ver muchísimas más personalidades. El día de hoy te la volaste, ¿no? Consiguiendo al doctor Jean-Louis TEBOUL platicando con nosotros de uno de sus escenarios más clásicos y donde ha sido un líder, donde ganó uno de los premios en 2007 por la Asociación Europea de Cuidados Intensivos. Y no es otra cosa más que, pues, evidentemente la respuesta a volumen, la administración de líquidos, en donde sin duda alguna es un líder, junto con la interacción cardiopulmonar, en la que también hay N cantidad de publicaciones. Por ahí en algunos de sus currículums se describen más de 129, 130 artículos en revistas arbitradas y más de 200 capítulos de libros, ¿no? Entonces, la realidad es que un excelente trabajo de tu parte y bueno, pues aquí estamos. Esperamos que esto sea de gusto para todos nuestros amigos de aquí de México y evidentemente veo que ya están conectados gente desde Colombia, mucha gente de Latinoamérica. Gracias, Juan, y bienvenidos a todos.
Gracias, Quetzalcóatl. Exactamente, lo has presentado y lo has dicho mejor que nadie. Estamos ante una gran personalidad a nivel mundial y por lo cual estamos sumamente agradecidos. Como bien dijiste, el doctor Jean-Luc Thibault desde París, Francia. Él trabaja en el hospital de Ventricle en París y ha escrito, como lo mencionas, N cantidad de publicaciones, artículos, prácticamente lo que sabemos actualmente de la administración de líquidos y de la interacción pulmonar es gracias a él y a su extraordinario grupo en París. Así que bueno, es por eso que estamos sumamente contentos. Hoy es un día muy especial. Abrimos nuestra temporada 3 de webinarios de una manera extraordinaria e increíble con una gran personalidad a nivel mundial. Así que démosle la bienvenida al doctor Jean-Luc Thibault. Thank you so much, Jean-Luc Thibault. Thank you for accepting our invitation. Thank you for spending part of your time with us. We are very, very happy for having you, Dr. Thibault. Thank you so much. And let's get started with your conferences, Dr. Jean-Luc. Thank you. Thank you once again.
Okay, thank you very much, Dr. Calderon, and I would like to thank all the people for the organization of this webinar. I will try to do my best to convince you that the issue of fluid administration in case of right ventricular dysfunction is finally a simple issue if we can understand some basic physiology principles. I have no conflict of interest for this presentation. As you know, in critical patients, there are major causes of acute RV dysfunction, RV for right ventricle. The first one is sepsis-induced mitral dysfunction, but also there is acute pulmonary embolism and also RV dysfunction due to ARDS, which is also a very common cause of RV dysfunction in ICU patients. And what could be the causes or the mechanisms responsible for pulmonary hypertension and RV dysfunction in ARDS? We have some mechanisms which are intrinsic, like hypoxic vasoconstriction, mediators related vasoconstriction, perivascular edema, microthrombi in pulmonary vessels, and also microvascular remodeling. All these causes, all these mechanisms can be responsible for pulmonary hypertension and finally RV dysfunction. But there is another one, which is related to mechanical ventilation. And you know that mechanical ventilation also can induce deleterious effects on the right ventricle. So if I summarize, I could say that sepsis-induced myocardial dysfunction can be responsible for acute decrease in contractility and finally in right ventricular dysfunction, acute pulmonary embolism, but also RV dysfunction due to ARDS and the effects of mechanical ventilation can in fact result in RV dysfunction due to an acute increase in pulmonary vascular resistance. So the first case is contractility. In the three other cases, it is pulmonary vascular resistance increase. But another way to classify all the causes of RV dysfunction can be this one. Sepsis, pulmonary embolism, and ARDS can be responsible for structural RV dysfunction. When I say structural, I mean intrinsic RV dysfunction, while the other one, the effect of mechanical ventilation, can be responsible for functional RV dysfunction, which can be reversible very rapidly. And I would like to well distinguish these two finally different categories, structural and functional, because the effects of fluid administration can be totally different, and as we will see in a few minutes. First, what about fluid administration in cases of structural RV dysfunction? And to do this, we have to look at, to go back to physiology. This is a very simple figure of the relationship between stroke volume and preload. You can put RV preload, right ventricular preload in the x-axis. You know, this is a Frank-Starling curve, and we have two parts. Preload responsiveness part, if the right ventricle is working on the steep part of this curve, and the preload unresponsiveness part, if the right ventricle is working on the flat part of the curve. And if the right ventricle is dilated, for example, due to a structural RV dysfunction, sepsis, pulmonary embolism, and intrinsic mechanisms responsible for pulmonary hypertension in ARDS, if the right ventricle is dilated, fluid infusion will not result in increase in right ventricular stroke volume because the right ventricle is operating on the preload unresponsiveness part. But in addition, we have to remember the diastolic function curve of the right ventricle with the RV endosteric pressure on the X and the Y-axis and the RV endosteric volume on the X-axis. And now the curve is like this. So if the right ventricle is not dilated, an increase in preload in the volume due to fluid infusion will not result in a high increase in the right ventricular endosteric pressure. But if the ventricle is already dilated due to a pre-existing or currently RV dysfunction, the increase in preload induced by fluid will result in a very high increase in the pressure. So, if the RV is dilated, fluid infusion will result in a large increase in RV endosteric pressure. So now, if we put together these two physiologic statements, we can also understand that the increase in the RV endoscopic pressure because of the interdependence phenomenon will result in a decrease in the left ventricular filling and finally a decrease in the left ventricular stroke volume. So therefore, in case of previous RV dysfunction and RV dilatation due to structural mechanisms, fluid infusion not only does not increase cardiac output, but can even decrease cardiac output. So if you give fluid to a patient with a structural RV dysfunction, with a RV dilation, normally cardiac output should decrease due to this interdependence phenomenon. Totally different is the effects of fluid administration in case of functional RV dysfunction due to the effects of mechanical ventilation. Totally different, and this is a totally different reasoning we have to do. Because we have to understand what are the relationships between pulmonary vascular resistance and lung volume. You know that there are two categories of vessels, microvessels in the lungs, the extra-alveolar vessels and the intra-alveolar vessels, which are directly in interference with the alveoli, while the extra-alveolar vessels are in the septa. So if you increase lung volume, for example, by mechanical insufflation or by increasing PEEP, you should dilate the extra-alveolar vessels, but you should squeeze or you should compress the intra-alveolar vessels. So the increase in lung volume should decrease the resistance of the extra-alveolar vessels. And if we represent this on a figure with pulmonary vascular resistance on the y-axis and lung volume on the x-axis, we should have this decrease in extra-alveolar vessels due to the increase in lung volume because of the stretching of the septa. RV for here, it is a residual volume, FRC for functional residual capacity, and TLC for total lung capacity. So you have a decrease, exponential decrease in the resistance of the extra-alveolar vessels when you increase lung volume. But at the same time, during mechanical insufflation, for example, you have an increase in the alveolar pressure, and this will increase intrathoracic pressure. But the transpulmonary pressure, that is to say the difference between alveolar pressure and intrathoracic pressure, should increase, of course, because the increase in intrathoracic pressure is less than the increase in valvular pressure during insufflation. And therefore, this increase in transpulmonary pressure should increase the resistance of the intra-alveolar vessels. If I represent this on this graph, we should have an exponential increase in the resistance of the intra-alveolar vessels. Because the shapes of these two curves are totally different, the resulting effect is like this, a U-shaped curve. It is a classical relationship between pulmonary vascular resistance and lung volume, a U-shaped curve, and the minimal resistance is for the FRC. The minimal pulmonary vascular resistance is for the functional residual capacity. If from this FRC which is the end expiratory lung volume, you increase lung volume by tidal volume during mechanical insufflation, you have a small increase in the pulmonary vascular resistance. So mechanical insufflation by a tidal volume increases pulmonary vascular resistance to a small extent if tidal volume is low, of course. If I increase tidal volume, I should have an increase in the pulmonary vascular resistance, of course. And what about PEEP application? Because in ARDS patients, we commonly use PEEP. In fact, there are two possibilities. If PEEP recruits lung units and increases the end expiratory lung volume toward FRC, like this, you should have a decrease in the pulmonary vascular resistance, a little decrease. And from this, you apply tidal volume during mechanical insufflation, and therefore you should have a small increase in pulmonary vascular resistance. So if PEEP is recruitive PEEP, beneficial PEEP if you want, the application of tidal volume should result in a small increase in pulmonary vascular resistance. Now, if PEEP increases the end expiratory lung volume above FRC, that is to say, if the resulting effect of PEEP is over distension, now application PVR increases and application of tidal volume results in a higher increase in pulmonary vascular resistance. So finally, if the resulting effect of PEEP is over distension, when you apply a tidal volume, even low tidal volume, you should have an increase in pulmonary vascular resistance. Of course, from this level of PEEP, if you apply a higher tidal volume, you should have a huge increase in pulmonary vascular resistance. But if the beneficial effect of PEEP is a resulting effect, you should not have a high increase in pulmonary vascular resistance. But in addition of this, you have the waist zones effect. And we have to look at the relationship between PVR and waist zones. As you know, it is generally, it is commonly assumed to divide the lung in three parts, from the bottom to the top. The waist zone 3, waist zone 2, and the waist zone 1 at the top. Waist zone 3 is defined by a region where the alveolar pressure is lower than the pulmonary venous pressure and the pulmonary artery pressure. Because in the bottom, you have the hydrostatic gradient, which increases the pulmonary artery pressure and the pulmonary venous pressure, and therefore these pressures are higher than the alveolar pressure. The flow is complete, full flow, and the resistance is negligible in this region. On the opposite, you have the zone 1 at the top, where the local pulmonary artery and the local pulmonary vein pressure are low because of the negative hydrostatic pressure gradient, because of the gravity, which is negative here. And therefore, you have some chance to have the alveolar pressure higher than the vascular pressures. There is no flow in this region. It is defined as a zone 1, west zone 1. And you have the intermediate region, zone 2, where the alveolar pressure is lower than the pulmonary artery pressure, but higher than the pulmonary venous pressure. And the resistance here are high. So the resistance go up from the bottom to the top of the lung. This is physiology. Now, how to combine the U-shaped relationship and the waist zones phenomenon? If your lung, if the totality of your lung is in zone 3, because you have a low alveolar pressure, or because you have a high pulmonary artery and pulmonary venous pressures, you have this kind of shape. And if you have a large part of the lung which is in zone 2, you have this different kind of shape. So now, if you apply PEEP, which is more over distending than recruitive PEEP, you start from the RFRC until the level of PEEP, which is now the end expiratory lung volume. And from this, you apply a tidal volume. If the majority of your lung is in zone 3, there is a little increase in PVR. But if a part of your lung is in zone 2, you have a higher increase in PVR. And if you apply a tidal volume, you have a high increase in PVR if part of your lung is zone 2. So zone 2 is very dangerous. Zone 2 is very dangerous for pulmonary vascular resistance, because if PEEP is not recruitive, and if you apply a certain level of tidal volume, and if you have some zone 2 in your lung, you have an increase in pulmonary vascular resistance. This is why it is better to have more zone 3 to limit the increase in pulmonary vascular resistance when you apply PEEP and when we apply a tidal volume. And interestingly, hypovolemia favors the extent of zone 2, because hypovolemia is able to reduce the intravascular pressures, the pulmonary artery pressure, but most importantly, the pulmonary venous pressure. And therefore, if you have a low pulmonary venous pressure for a given level of alveolar pressure, PEEP plus tidal volume, you should have a large part of zone 2 in your lung. And therefore, the pulmonary vascular resistance should be high. So a situation of hypovolemia can be associated with a high pulmonary vascular resistance. So reduced central blood volume or central hypovolemia should amplify the deleterious impact of mechanical ventilation plus PEEP on the right ventricular afterload and on the right ventricular function. And this is well illustrated by this study we performed some years ago with Émilie Fougère and Xavier Monet. We studied patients with ARDS, ventilated with a tidal volume of 6 ml per kilogram. And at the beginning of the study, we have a low level of PEEP, 5 centimeters of water. And we increased PEEP without changing tidal volume to reach a maximal plateau pressure of 30 centimeters of water. And on average, in this population of patients, the level of PEEP, what we called the high PEEP, was 13 centimeters of water. And we performed a passive leg raising, not to predict field responsiveness in these experiments, but to simulate a volume challenge, like a preload challenge, like giving fluid. And we measured the effects with a Swan-Ganz catheter and with echocardiography. What we observed, we have two columns, the minimal PEEP, 5 centimeters of water, and the high PEEP, on average 13. As you can observe, when we applied high PEEP, we had a decrease in cardiac index. It was not a new finding, of course. But more interestingly, we have an increase in pulmonary vascular resistance, and an increase in the gradient between the mean pulmonary artery and the POP. And also using echo, we observe an increase in the right-left endosseal ratio. That is to say, a displacement of the septum to the left due to this high PEEP level. So all these findings were consistent with an increase in RV afterload with PEEP. It is not a new finding, of course, but what was new was the effect of passive leg raising as a simulation of fluid infusion. Because we observe an increase in cardiac index, we observe a decrease in the pulmonary vascular resistance, huge decrease, and also we observe a decrease of the right to left ventricular endosseal ratio. So, meaning that there was a displacement of the septum now returned to the right. And therefore, all these findings were consistent with a decrease in the right ventricular afterload with volume. In other words, the effects of volume or fluid infusion were to decrease the RV afterload and to improve the RV function. Probably when we gave volume, we increased the extent of zone 3 conditions, because by increasing the pulmonary venous pressure, we should reverse the relationship between alveolar pressure and pulmonary venous pressure, and therefore we can transform zone 2 to zone 3 conditions and finally decrease pulmonary vascular resistance. So we have to keep this in mind when we manage patients. So now, in the last slides, I will try to see with you the issue of fluid administration or restriction in ARDS. First, of course, we have to think about the presence of hemodynamic instability. There are two possibilities, yes or no. If no, there is absolutely no reason to give fluid to this patient, of course. And we know that accumulating fluid balance in this kind of patients is an independent factor associated with mortality. This is a study we did in ARDS patients with Mathieu Josviak and Xavier Monet. Some years ago, we studied 200 patients with severe ARDS and a high mortality rate, and we observed that the mean fluid balance in these patients was an independent factor associated with mortality. So we know that it's not good to give fluid to ARDS patients when we have no reason to give fluids, when we have no hemodynamic instability. Okay, now go to the other part of the slide. We have hemodynamic instability. Could be vasoplegia, could be hypovolemia, or could be RV dysfunction. If it is vasoplegia, it could be interesting to look at the diastolic pressure, because as you know, the diastolic pressure is a good marker of arterial tone, and a low DAP is indicative of vasoplegia, and you should consider the administration of vasopressors like norepinephrine. The most difficult issue is to detect the presence of hypovolemia and to think about the fluid administration. But before giving fluid in this kind of patients, because the high risk of worsening lung function and creating pulmonary edema, we have to assess the benefit-risk ratio of fluid infusion. So we have to assess the benefit, which is the degree of fluid responsiveness, and the risk, which is the risk of worsening of lung edema. For the benefit, I don't want to go into details today. You will have to look at to use some hemodynamic dynamic variable or dynamic test of fluid responsiveness, pulse pressure variation, stroke volume variation, tidal volume challenge, passive leg raising, and the expiratory occlusion test, IVC diameter variation, whatever. You could assess the degree of fluid responsiveness or fluid unresponsiveness. To assess the denominator of the benefit-risk ratio, which is a risk, we have to look at some measures, PF ratio, of course, but also extravascular lung water, which is a good quantitative measure of lung edema, and also pulmonary vascular permeability index, which is a good marker of lung capillary leak. And these variables are associated with mortality in ARDS. The same study I showed before, we also showed that PVPI, the maximal value of pulmonary vascular permeability index, was an independent factor associated with mortality as well as extravascular lung water. And these variables can be obtained using transperineal thermodilation systems. And recently, the European Society of Intensive Care Medicine proposed a very simple decision tree in case of acute circulatory failure. And we proposed in case of ARDS plus shock to either use transperineal thermodilation systems or PA catheter. You have the choice between two. The advantage of transperineal thermodilation is to provide extravascular water and PVPI. So you assess this benefit-risk ratio, but also you have to consider the context. That is to say, the severity of hemodynamic failure versus the severity of respiratory failure. For example, if you have a very severe hemodynamic failure with high lactate, renal failure, etc., maybe you have to also prefer to use fluid, to give fluids. If you have a very severe ARDS, even if the patient is still fluid responsive, maybe you have to choose to not to give fluid because of low PF ratio, high lung water, etc. And after, you can make the decision to give or not fluid infusion. And the third possibility of hemodynamic instability is RV dysfunction, as we saw before, which could be in ARDS either due to pulmonary hypertension related to what I said before, hypoxic vasoconstriction, etc., or to the effects of mechanical ventilation plus PEEP, as we saw before. And in this situation, we have to look at how to say the benefit of fluid administration versus the risk. But sometimes we know that excessive fluid restriction can worsen RV dysfunction by creating some relative hypovolemia and favoring zone 2 conditions in the lung. So we have to think about this. And if you are not sure of what to do, I would recommend to perform passive leg raising and to look at the effects on echo, for example, findings, and to look at the RV, LV, and the diastolic ratio, and the area ratio, for example, and to see, because the passive leg raising is a good reversible test, so you cannot create pulmonary edema with this. So finally, as you can observe, we have many possibilities, and we should not always use fluid restriction in ARDS, because sometimes we can create some aggravation, worsening of pulmonary vascular resistance, and finally we can aggravate RV dysfunction. So if I summarize, I would say in congenital patients, RV dilation may occur due to structural causes, pulmonary embolism, ARDS-related pulmonary hypertension, septic myocardial dysfunction, etc. And in these situations, fluid infusion cannot increase cardiac output and can even decrease cardiac output. In mechanically ventilated patients, RV dilation may also occur due to mechanical ventilation itself, due to the high pulmonary transpiratory pressure, increasing the pulmonary vascular resistance due to extension of zone 2 conditions. And by increasing pulmonary vascular pressure, fluid infusion, pulmonary venous pressure, fluid infusion can restore zone 3 conditions, and thus decreasing pulmonary vascular resistance, decreasing RV size, and can finally increase cardiac output. So you can see that we have two different behaviors in function of structural versus functional RV dysfunction. In case of any doubt, you can perform a passive leg raising test. It can be very helpful, and because, for example, in ARDS, you can have a mixture of structural and functional causes of pulmonary hypertension and RV dysfunction. So don't hesitate to perform a passive leg raising test and measure using echo the results. In any case, the benefit-risk ratio of fluid infusion must be carefully assessed anyway, essentially in ARDS where the capillary permeability is altered. I would like to thank you for your attendance. Muchas gracias.
Thank you so much, Dr. Jean-Luc. It's very amazing presentation. Thank you so much, Doctor. Let's move on to the part of the questions. Doctor, this is a very common in our settings, in our hospitals, having patients with ARDS, as you have mentioned, with both conditions, structural and functional abnormalities. In this case, sometimes even the patient is on the prone position. So in this case, we cannot perform a passive leg raising, but in your opinion, doctor, what is the best method to evaluate fluid responsiveness in patients on the prone position?
This is an excellent question. And today we have no definitive answer to this question. And because there are not so many studies, there is one study published now 2 years ago. I think it was January 2017 in critical care by a group of Lyon in France, the group of Claude Guérin. You know Claude Guérin, who is an expert in prone positioning, and they proposed to perform a Trendelenburg test, which consists in moving the bed of the patient where the final position is minus 30 degrees. The head is below the trunk, and this is like a inverse passive leg raising test.
Okay.
And this can increase cardiac output in patients who are fluid responsive. But your question also leads to another one, which is the effects of prone positioning on RV dysfunction. And this is very interesting because prone positioning can improve right ventricular dysfunction by decreasing a lot pulmonary vascular resistance. Because prone positioning first can reopen some lung regions, of course, recruiting. So recruitment is good because by recruiting lung, you can go towards the FRC from a small lung, a baby lung, to FRC. So if you remember the U shape of the PVR and lung volume, you can decrease pulmonary vascular resistance by recruiting. And maybe it is still better than PEEP. And from this, you also have an increase, you can increase venous return by prone positioning. And you also have an increase in pulmonary venous pressure by increasing the central blood volume. So you have an increase in pulmonary venous pressure, so you have less zone 2 conditions, more zone 3. So you have two reasons to finally improve PVR. First, you recruit lung, and second, you have less zone 2 conditions.
Right.
And we published a paper in the Blue Journal 4 years ago, or 6 years or 5 years ago, I don't remember, 5 years ago now, with Mathieu Josiac and Xavier Monet, where we showed that the pulmonary vascular resistance can improve a lot during prone positioning. So you can improve patients with RV dysfunction. And for me, it is another reason to prone patients.
Yes.
To select patients with RV dysfunction, you can improve their RV dysfunction by recruiting lung and also by increasing the pulmonary venous pressure. So this is an interesting debate.
Yes, thank you, doctor. No sé, Quetzalcóatl, ¿me estás escuchando por ahí? ¿Quetzal?
Sí, Juan, te escucho.
No sé si quisieras hacer algún comentario más o alguna pregunta.
Me gustaría hacer dos preguntas, si quieres, antes de pasar, porque veo que ya empiezan a preguntar, por aquí por el chat.
Exacto.
Doctor, thank you so much for the talk and the conference. And I have a question. It is well known that static fluid responsiveness predictors are not reliable as the dynamics ones. But when you talk about passive leg raising in patients with a functional dysfunction of right ventricle, you recommend to measure the right ventricle and diastolic area. So what will be the mean value to reduce the right ventricle and diastolic area to consider a positive or a patient with fluid responsiveness during this situation?
What I recommend is, because there is a common idea, which is when you have RV dilation, you should not give fluid. You know, some people say, oh, you are RV dilation, you should not give fluid, even if the patient is in shock. This is a common idea. You already heard this idea already. For me, maybe if you have a structural reason to have RV dysfunction, it's not a good idea to give fluid. You can worsen, you can increase further the right ventricle. But as I tried to show, you have some functional reasons to have RV dilation. And sometimes it is a good idea to give fluid to restore zone 3 conditions in these situations. So when we have a RV dilation, I would recommend to perform passive leg raising just to see if the RV dilation increases, which can indicate that the majority of the causes of RV dilation are structural, and this is not a good idea to give fluid, but there is no risk to perform PLR in this condition. Or if you have a reduction of the RV over LV intercircular ratio, which could indicate that finally fluid was beneficial by recruiting capillaries and by reducing the PVR. So I recommend to do this, but of course you need echocardiography or something like this to assess the effects. Otherwise you cannot know. You understand the point?
Yes, but I will set an example. For example, if you have right ventricle and diastolic area over left ventricle and diastolic area over 7, for example, and you perform the passive leg raising, and this ratio decreases to 0.65, is it still over 0.6? Will you consider to give fluids or not?
If the patient has hemodynamic instability, yes. In this case, yes, because the ratio would decrease, so indicating that you are recruiting capillaries by fluid, by decreasing the zone 2 conditions. So this is beneficial. Of course, if the patient has no hemodynamic instability, there is no reason. There is no reason to do this. Only if you have to choose between norepinephrine, fluid, inotrope, etc., you have to test this. This is very simple to do. If you perform echo, of course, you need echo. Otherwise, it's difficult. I agree. But this is just to how to say, to test the effect of fluids. It is reversible, totally reversible. There is no risk of edema, there is no risk of liver failure, nothing, because you have just to do this for 30 seconds, 1 minute, and this return to baseline after the test. So it is very simple, and sometimes you can have good surprise, patients who benefit from this PLR, and finally, who can benefit from further fluid administration. So there is always a balance, and my recommendation is to test before giving, and not to say, oh, there is RV dilation, so I don't give. No, sometimes maybe you can. It depends.
Okay, thank you so much. And there's another question. Biller-Baron published years ago a protocol like imitating something like protective ventilation to the right ventricle. And he steps 2 or 3 goals to achieve this issue, like reduce plateau pressure to less than 27 centimeters of water, reduce PCO2 to less than 60, and probably to reduce PEEP if the total or the net effect of PEEP is increasing pulmonary vascular resistance. So would you consider to achieve these goals before the fluid administration, or would you consider to achieve these goals at the same time you check fluid responsiveness on these patients?
It's a complicated question, of course, because I'm not totally in agreement with what Antoine said. Because if I have to choose between tidal volume and PEEP, I would prefer to reduce tidal volume instead of decreasing PEEP. Because sometimes PEEP can be recruitive, and if you, maybe I can see if I can go back to
to the graph with RC and
exactly,
and the total lung capacity, right?
Yes, for example, this is important to understand. Of course, it is schematic. Nevertheless, normally when you have ARDS, your end expiratory lung volume is lower than FRC. So you are on the part on the left part of the curve. So if people is recruiting is good in terms of recruitment, you should decrease finally pulmonary vascular resistance. Of course, after, if you apply tidal volume, okay, finally you have a small increase. But of course, if PEEP is over distending, it is a problem. You have an increase, and if you apply tidal volume, you are a further increase. So saying that PEEP is always bad, I'm not sure. It depends. You have to test if PEEP is more recruitive than over distending. And in addition to this, even if it is over distending, this is the example I gave later in my talk, even if it is over distending, if your lung, the totality of your lung is in zone 3, meaning that all the capillaries are open, you have a minimal increase in PVR with PEEP compared to if you have central hypovolemia. So after, when you apply tidal volume, of course, you have a higher increase in PVR, but even if you are in zone 3, but a huge increase in PVR if you have some part of the lung in zone 2. So what is important is PEEP, tidal volume, and volemia. It is how to say, there are three actors, PEEP, tidal volume, and volemia, central volemia. And you have to play with these 3 actors. You understand?
Yeah.
You cannot have a rule for everyone. It depends. I would consider that PEEP is important to recruit, but maybe prone positioning is more important, because prone positioning does not overdistend. It is always recruitive. So normally you can decrease PVR, and after tidal volume can increase PVR, but if you don't use high tidal volume, normally you should not increase PVR, and you should increase PVR if your lung has a large part of zone 2 conditions. So you have 3 actors, and you can play with these 3 actors. You can have different scenarios depending on the patient.
Okay.
Thank you, Dr. Jean-Loup. And also, sometimes in only one patient we can see different conditions, because sometimes the part of the lung is over-distended and some parts of the lung are not distended. I mean, this is heterogeneous, so we can different conditions. Dr. Jean-Loup, what about the right ventricle infarction? Is this a structural or this is a functional dysfunction? And what we have to do in case of right ventricle infarction? Because it is said that we should increase the CVP, even though we know that CVP is not is a good marker or is not good for predict volume responsiveness. However, there are physicians who think that we should give more fluids in case of right ventricle infarction. What's your opinion about this specific condition, doctor?
Sorry, I missed your first minute because the sound totally disappeared.
Right. Okay, I will repeat.
I can hear you now, but I couldn't.
Okay, no problem. I will repeat. What about in case of right ventricle dysfunction because of myocardial infarction? What should we do in this case about the fluid responsiveness or fluid administration, specifically in right ventricle myocardial infarction?
To be honest, I don't know. I cannot answer definitively about this.
Okay.
I think that normally it could be an indication to give fluid, but again, I don't want to give any fluid in any patient without testing fluid responsiveness.
Right. Exactly.
So I don't care about CVP in this situation, because of course you have a high CVP, but the patient can be fluid responsive. So I would test again if fluid is beneficial or not by performing tests. But the myocardial infarction in general is not associated with RV, increase in RV afterload. So it is another condition of RV dysfunction, which is not in general associated with RV dilatation. But again, in this situation, as in others, I would test fluid responsiveness before giving fluid. Even if it is well known that we can give fluid in this situation, but I would be very careful. I would test before, really.
Okay, thank you, doctor. It's okay, I agree. And well, there are some questions from the audience. Do we have time, Dr. Jean-Loup, for questions from the audience? Okay, Quetzal, no sé si quisieras leer algunas.
Just a Champions League game in 1 hour, but Paris against Manchester, but I have 1 hour.
Okay, thank you. Quetzal, si quisieras leer alguna de las, mientras yo voy a buscar si hay en Facebook alguna pregunta.
Claro que sí. Doctor, there's a question from the auditory. Dr. Leo says, thank you very much for the amazing conference. And he asked, in the case we cannot perform a passive leg raising test, or we are not sure of the response, do you recommend bolus load to assess fluid responsiveness or not?
If we have no choice, yes, I would say yes. Of course, sometimes we cannot test. I think that if you use echo, you can perform passive leg raising and look at the changes in velocity time integral. But of course, you need echo, and you need to know how to use echo, of course. Maybe 100 ml, the mini fluid challenge. 100 ml can be recommended in this situation. But you know, giving 500 is a lot.
Yeah.
You know that the total plasma volume in a normal human being is 3.5 liters on average. So giving 500 is not nothing. It's not nothing. It is a huge amount. And people do not realize that when they give 1 liter, they give 1/3 of the total plasma volume of the patient.
Of course.
So I would recommend, if you have no possibility to perform PLR, pulse pressure variation, and the expiratory occlusion test, tidal volume challenge, whatever, I would recommend to be very careful and to test 100 by 100 ml.
Okay, thank you so much. There is another question from a guy who's namely Galaxy S8. I mean, he doesn't let his name, but he asked about pulse pressure variability and systolic pressure variability in patients with very low tidal volume. If it is an reliable measurement for fluid responsiveness or not. And what about if those patients are also in prone position ventilation? Will you use it or not?
So in low tidal volume, meaning, in fact,
6 per kilo, probably.
6 per kilo, which is a normal tidal volume now. So, so 6 ml per kilogram is not a good, how to say? I don't say that we cannot use pulse pressure variation. I said that we have to be very careful about the interpretation of pulse pressure variation. If you have a high PPV, pulse pressure variation, in case of low tidal volume, you can be almost sure that the patient is fluid responsive. I would say if you have 14, 15% with low tidal volume, in general, the patient is fluid responsive. But the opposite is not true, meaning that you can have a low pulse pressure variation, 7%, for example, and the patient can be fluid responsive. So this is a limitation of pulse pressure variation. It's not a contraindication, it is a limitation. In this case, one possibility is to perform tidal volume challenge. This is a test which has been proposed 2 years ago now, but there is only one paper, only one study published so far in Critical Care Medicine, 2017. And this is a study we did with a group of intensivists of Mumbai, India. And we proposed with Sheila Mayatra as the first author, and we proposed to increase tidal volume transiently for 1 minute maximum, and to look at PPV. There is no need of cardiac output monitoring device, nothing, just PPV. And if PPV increases by more than 3.5% in absolute value, the patient will respond to fluid administration. If PPV increases by less than 3.5%, the patient is not fluid responsive. So in other words, if you have a PPV of 7%, you increase tidal volume transiently from 6 to 8, you look at PPV. If PPV is now 11%, starting from 7,
responsiveness, yeah,
the patient is fluid responsive. If PPV is now 9%, just 2% increase, the patient does not need fluid administration. But I need to be very careful. I have very careful for this test because there is only one study. So we need more studies,
yeah, to validate the data.
Sure, yes.
Yeah. Okay.
But it is a possibility.
Okay, thank you so much. Do you want, Juan, ¿quieres tú leer las otras preguntas? Estás en silencio, Juan.
Okay, thank you. Okay, doctor, there are some other questions. Some physicians are asking about the possibility to use inotropes in case of right heart or right ventricle failure. What about what's your opinion, for instance, for using milrinone in case of high pulmonary vascular resistance and dilation of the right ventricle, should we use some specific kind of inotrope in case of unresponsiveness to fluids in case of right heart failure, Dr. Jean-Luc?
Yeah, so thank you for the question. In fact, as you said, if you need to use an inotrope for RV dysfunction, it could be for sepsis-related RV dysfunction, for example, because in case of pulmonary embolism, as well as in case of ARDS, the problem is not contractility, is more the increase in pulmonary vascular resistance. So it's not logical to give an inotrope in this situation, except if the inotropic drug also has some vasodilating properties for the lung vessels. This is the case for milrinone. It is the case for levosimendan. They also have some pulmonary vasodilating properties. And for example, levosimendan, with Andrea Morelli from Italy, we published a paper some years ago in ARDS patients showing that levosimendan can decrease a lot pulmonary vascular resistance compared to placebo in patients with RV dysfunction plus ARDS. So this is a possibility. It is more logical to give levosimendan or milrinone, which has more or less the same pulmonary vasodilating effects than dobutamine, for example.
Exactly. Actually, your colleague Antoine Villar-Baron, I don't remember, but he published something related to, and they described how the cardiac index of the right ventricle increased when they apply or when they administer levosimendan. Am I right?
Yeah. We had the same. We were in the same study with Andrea Morelli. So we found the same result, an increase in cardiac index, a decrease in pulmonary vascular resistance, and improvement in RV function, yes.
Exactly. Okay, doctor, apparently there are no more questions also in Facebook. There are another one, okay. In pulmonary vasodilation of any use when facing an increase in pulmonary resistance, if high PEEP is deemed necessary. Is pulmonary vasodilation of any use when facing an increase in pulmonary resistance? I don't understand very much this question. Ketsa, ¿tú entiendes esta pregunta última de Galaxy?
Yeah, doctor. They're asking if there's a role of pulmonary vasodilators in the patient that you have an obligation to increase the PEEP because he is on respiratory failure. They are asking if you will consider to use pulmonary vasodilators. I don't know, like nitric oxide or any other drug that dilates pulmonary vascular vessels.
So the question is, you are obliged to use a high level of PEEP.
Yeah.
So you create some overdistension of some lung areas, and you have an increase in PVR, and you want to decrease PVR by another way, a pharmacological way. Okay.
Yeah.
I would say if you have a high increase in PVR, look at the graph here on my slide. If you have a high increase in PVR with PEEP, is that probably PEEP is not the good way to do, because normally it should not increase as much again, or the patient is volume depleted. And we have a lot of zone 2 conditions again. And in this situation, I would prefer prone positioning, really, because you can recruit more without increasing pulmonary vascular resistance. So again, if you have to deal with the problem of RV dysfunction due to high level of PEEP, you have to rethink about the indication of this high level of PEEP and think about the switch to prone positioning. So This is my answer because this is what I live every day. I experience every day. So normally, if you use a high level of people and you are over distending, you should think about switching to prone positioning, really. And also think about is volemia, is volume, is central blood volume appropriate or not? Again, think about the zone 2 conditions and prefer zone 3 conditions in this situation.
Okay.
But of course, you can use inhaled NO, of course, you can use it. But you have to rethink to the situation. If you are so deleterious with PEEP, maybe is that PEEP is not the appropriate way to recruit. And I would propose, I would try prone positioning in this situation.
Okay, I have one question, doctor. It is well known that the beneficial effects of prone position for patients with acute respiratory failure with a POFO ratio less than 150, and also it is well known the beneficial hemodynamics effects of prone position. But what would you consider the principal causes that a patient cannot respond to prone position ventilation? I mean, the patient is on respiratory failure, you put on prone position, and instead of increase oxygen saturation or blood pressure, it decreases, and he gets a circulatory collapse, or even he gets hyposaturated. So what would you consider in that case?
Of course, if the patient does not respond to prone positioning, if the plateau pressure is already high, this is indication of ECMO. In our countries, we use ECMO in this kind of situations.
Right.
Okay, thanks so much.
Okay, thank you, Doctor. Gracias, Quetzalcoatl. Well, Dr. Jean-Loup, we are going to finish the webinar. We really appreciate your attention and your willingness for joining us. Doctor, do you have some last words for our Latin American and Mexican audience? Do you have a take-home message for our audience, to our audience in Latin America?
Regarding the topic of today?
As you prefer.
Yeah. No, first, in general, you know that I love Latin America, and I travel a lot to Latin America, to Mexico, but also to South America countries, and also to Panama. And I go every year to Panama. I go also to Mexico every year for the National Congress, and in other countries also in South America. So I like a lot the Latin American people. So this is a general message I have to give. And not only, no, very, very kind people, very intelligent people, very easy to speak people. So I love, I would say.
Thank you.
Regarding my topic of today, the only message I want to say is we have to test in a given patient what to do, and not to consider and to follow a general rule which probably does not apply to this patient. And the problem of fluid administration in case of RVD dysfunction is a good example. Is a good example because it can be forbidden to give fluid in case of structural causes of RVD dysfunction, or it could be indicated to give fluid in case of functional cause of RVD dysfunction. And this is the problem of today. I wanted to, I don't know if I managed to do, but I wanted to insist on this point. And because we have sometimes the mixture of functional and structural, it is good to test before by performing a PLR test or something like this.
Exactly. Thank you. And also you have been very demonstrative, and we are very, very thankful for that. Quetzalcoatl, do you want to say something for our Latin American audience?
I'm going to talk in Spanish just a little bit, doctor. Muchas gracias a todos los que participaron en este webinario, a todas las personas que hicieron preguntas. Espero que hayan quedado cubiertos todas las preguntas que se hicieron a través de aquí del chat de Zoom. Y bueno, solamente invitarlos, ¿no?, a participar con nosotros en estos webinarios. Sin duda alguna, ya en esta tercera temporada hemos incrementado la cantidad de gente que se conecta. Evidentemente son temas de una naturaleza que interesa siempre al intensivista, obviamente tópicos que seguimos viendo, a pesar de no tener a veces algunas herramientas, pues no necesariamente hay respuesta alrededor del mundo, ¿no? Dicotómica, y lo que siempre hemos comentado en las terapias intensivas, ¿no? Evaluar siempre la tendencia del paciente y la condición previa a hacer alguna maniobra, pues es sumamente importante, y la respuesta a esa maniobra pues es vital para conocer la evolución que tiene el paciente. Y en el caso de la disfunción tanto estructural como funcional del ventrículo derecho y la posibilidad de respuesta a volumen, pues no es la diferencia. Todavía seguimos en ese terreno gris, ¿verdad?, que le llamamos de, pues hay que evaluar. Todavía no hay una herramienta precisa, dicotómica, que nos permita decir nos vamos hacia un lado o hacia otro, pero la idea es seguir buscando, investigando y participando, ¿no?, en este tipo de foros para conocer los puntos de vista, pues, alrededor del mundo. Muchas gracias a todos los que participaron. Esperamos que les hayan gustado. Si les gustó, pues por favor nos dan un like ahí en la página de la Asociación Mexicana de Ultrasonografía. Y por favor hagan sus comentarios de temas de interés para ustedes. ¿Qué otras cosas les gustaría que se tocaran en estos webinarios? Estamos en la mejor disposición de participar con ustedes.
Así es, Quetzal, muchas gracias. Y también recordarles a nuestra audiencia que este webinario tiene aval del Consejo Mexicano de Medicina Crítica, por lo que van a tener una constancia. A los que entraron por la plataforma ha quedado registrada el tiempo de permanencia, así como de sus correos electrónicos. Por lo tanto, les vamos a mandar una constancia de este webinario que ha sido avalada. Y pues, como dice Quetzal, pues de verdad agradecerles a todos su participación. Y bueno, pues vamos a despedirnos. Dr. Jean-Luc, thank you once again for accepting our invitation. We are very, very happy for having you. Really, we admire your works. We are very thankful for all your contribution and all your papers and conference and all your consensus you have written. Thank you so much, Dr. Jean-Luc, and welcome to Mexico. Will you be in Mexico on the next National Congress, right?
Yes. Normally, yes. Normally.
Okay, thank you. Hopefully we can meet you in that Congress.
And to other countries in South America too. So.
Yes, in Peru also. Yes.
Peru and Colombia and all others.
Exactly. Thank you, Doctor.
Thank you very much. Thank you very much.
Thank you very much.
Bye-bye, everyone.
Thank you. Bye-bye. Gracias a todos. Hasta luego. Bye a todos.
Bye.